management, medication management, you would get referred to a speech language pathologist within that setting. And I would always hear, oh, my loved one can speak just fine. I don't need a speech language pathologist. I don't know what you're doing here. And then I would have to explain to them why I was there. And we work on that cognitive communication breakdown of following directions, sequencing, problem solving. But what I was hearing over and over was that somebody received a diagnosis, whether that be, Parkinson's patients, whether that be a dementia diagnosis. And they would say, we heard from our neurologist, they said, see you back in a year, but there wasn't really much in the in between. And when I was in skilled nursing, I wasn't seeing them until they were already in more of a crisis situation. Whether they were there for rehab to home because they had a fall, maybe they had a hip replacement and they needed a rehab stay, or because they needed a transition of increased level of care. And so they moved into either assisted living, memory care, or long-term care. And over the time, hearing how frustrated families were, I thought, you know what, I'm going to start something and I'm going to go out into the community and I want to meet people where they are. So I have a private practice that is specific to the cognitive communication decline of all of the dementias, Lewy body being one of them, which of course is associated with Parkinson's, and also Alzheimer's. And so I am an in-home mobile private practice. I go to the home, and then I also do dementia family coaching as well. That is like a private pay basis. The Medicare part is covered, the therapy, but I coach families through, things like, how do we talk to our loved one about having increased care? Some of the hallucinations, delusions, some of the wanting to know what type of activities they should be setting up for their loved one, knowing how to communicate with their loved one the best way, going over resources in the area, and kind of helping them answer questions that they can't feel like they get asked just within their small session of like their neurologist appointment. You have such limited time. And in my experience, oftentimes we get there and they ask how we're doing and we say we're doing fine. And we have 15 minutes to share everything. So I try to meet families where they are, and I support not just the individual with the diagnosis, but also the care partner. And just like Kim said, it truly takes a village, and everybody on here, could be someone's village and help them on their journey.
Excellent. Well, I'm gonna start off with this one. This is my personal one I've run into. I've got a loved one, family member, who was misdiagnosed for about 4 years, that it eventually found out it was Parkinson's. We kept asking if it possibly could be neurological, because literally she basically woke up one day frozen, and she couldn't lift her head, she couldn't lift her arms, she couldn't write, she couldn't, and I really can't even replicate how slow her movements were. It was glacial, and you try to copy it, and then your brain would take over and you move quicker. But for her to reach for her glasses or whatever was forever, standing up. And through a different medical crisis, she was in the hospital, and this was like 4 years into this diagnosis, and the doctors just kept telling us, it's arthritis, and that's what's causing the pinched nerves, which is causing all these other issues. And she's in the hospital for something else. This one doctor goes, I think you may have Parkinson's. And he goes, so I'm going to give you this pill. He goes, it's either going to work or it's not. He goes, if it's not going to hurt you. Okay. So he gave her this magic pill. Okay. And in our family, it's totally magic, because 20 minutes later, she could do all these things she hadn't been able to do in 4 years. And even now, we have a real hard time years later when we see her just stand up from her chair and walk across the room. We're kind of like, it just kind of freaks us out. We're, it was like, she had this, she was in an ice cube frozen for 4 years, and now she's moving again. Is misdiagnosis a common situation, or what are we running into on that? Whoever.
I might jump in if it's okay.
Yes, please.
As a care partner, it took 4 years for Thomas to get properly diagnosed, because there is no brain scan, there is no blood test. There's a pill that might work as a part of the diagnostic process. And often people are misdiagnosed. And levodopa, carbidopa is the mainstay. It's the gold standard to this day for Parkinson's disease, and it's 60 years old. I think it was developed in the late 50s, and it's still the gold standard. But here's the thing about levodopa, carbidopa. It does a very good job of masking the motor symptoms, but the disease is still progressing. And the person is having changes in their voice and having expiratory and inspiratory strength trouble. And you can have a false sense of wellness by just masking those symptoms, and you're not really addressing the rigidity. And it's really easy to get in a state of denial until the symptoms, like Jesse said, until it's too late, until Thomas choked and I had to give him the Heimlich. We didn't go see a speech pathologist. Mm-hmm. So hopefully, Jim, this type of tribe that people can recruit as soon as possible after diagnosis as a intervention for disease management. I think there's a shift going on, but it is important to establish your trusted tribe of individuals because not every PT, OT, speech pathologist understands the complexity of Parkinson's.
So you're rock steady boxing, and so let's just say that somebody now they know they have Parkinson's. Maybe they're masking it, but now they know they have this particular thing. And they find out that what you guys do is a benefit. How do they tell me about what that process is? They call you. I'm sure that they're like going, boxing, this makes no sense. So could you kind of take that new person that's looking from the outside going, what the hell am I doing? and find out how to walk through that process a little bit.
Yeah, well, the beauty is that some of these resources like Rocksteady and other programs for exercise specifically are in the neurologist's office now as a trusted resource. And that's where we have to be the best that we can be, have trainers that have proper certifications, have a safe facility, have research that backs what we do. So the neurologist can trust that that is a valid resource and people aren't going to be hurt. So, we refer people to the climb all the time because boxing is not everybody's wheelhouse. Some people need a kinder, gentler approach that's more one-on-one as opposed to a group dynamic. So having an awareness of all these excellent programs around us allows us to understand our out-of-scope issues, first and foremost, and make the proper referral to what is going to match that person's personality and what they're going to adhere to. So boxing just happens to be the hook, but we're doing a lot of real specific exercises that address symptoms of Parkinson's disease. We don't talk about it a lot in a clinical way, and I think some people like that because folks spend a lot of time in clinic talking about their disease.
Hey, Jim, can I go back to that original question?
Yeah.
I really appreciate what you shared about that, Christine. And I just wanted to kind of reiterate in a different way what you were saying, that the symptoms of Parkinson's early on a lot of people can very easily talk themselves into the fact that it's aging. It's just normal. This is what happens, unless it's early onset. I think that might be a little bit more straightforward, perhaps. I don't know, in terms of getting to the right doctors quicker. But a neurologist is who you need to see for this diagnosis. Most general practitioners are not going to feel real comfortable or knowledgeable to make a diagnosis on their own about something like this. And we all know how long it takes to get into a specialist. So, I mean, it can be quite some time for our patients to get that initial appointment to see a neurologist. So from a lot of discussions and a lot of conversations I've had with people in my support group, I've just heard over and over, oh, I wish I'd pushed more. I wish I'd asked. I wish I'd advocated more early on to get to that neurologist. So I guess my message is, you know your own body, you know yourself really well. And if you feel like there's something more going on than what should be happening, it's not going to hurt anything to consult with a neurologist and find out. Best news would be, nope, I don't think it is Parkinson's, and it can really kind of alleviate that. But advocate. Don't be afraid to ask for what you want.
And Julie, you're a professor at IU, right? Down in Bloomington, is that where it is?
Yep.
Now, do you see clients, or are you teaching other people to go out and see clients?
Both.
Okay, I just didn't know if you actually, so
Yeah.
people can come and see you.
Absolutely. Yeah.
Okay. Yeah, absolutely.
Yeah.
So I just was trying to make sure I understood how your role played in.
Well, I supervise the graduate students that are doing their clinical training to become speech therapists.
Okay.
And so yesterday we met with a wonderfully funny 70-some-year-old lady that we did a speech and swallow and language assessment on her. And we're going to get started with LSVT next week with her.
Excellent.
Yep.
Kim, the Parkinson's Foundation, Indiana Parkinson's Foundation. So the same topic we're on here, someone's newly finds out they have it, or maybe they suspect they have it. For us, we literally were asking these doctors we're going, this doesn't make sense to us for 4 years, and they just kept blowing us off. But what do you recommend for people? Do they come to you to go, gosh, we're just curious, or how does this work out?
Right. So we will have, people contact us for many reasons. Maybe they're looking for neurologists in their areas. Maybe they're looking for exercise. Maybe they're looking for, support systems, whatever it may be. And we of course address their original questions, but I think everybody on this call will agree that one of the biggest things that we can do for them is educate them. And so I think that when we are able to educate them in the area that they're requesting, and maybe other areas too, that gives them and equips them with the information they need to go to their doctor and talk with their neurologist and say, hey, this is what I'm dealing with. I'm having a loss for words, or I'm having issues with word recognition or coming up with words. And that education on what they can talk to their doctors about is huge in their own advocacy, right? So they're able to be their own advocate, or maybe it's their caregiver that's doing that advocacy. But the more that we can give them the education so that they can have those informed conversations with their doctors, whether it be way in the beginning when they're talking with the GP, or when they're in the neurologist or the movement disorder specialist office. I think those pieces of information that they can take with them in those situations is key. So really coming alongside with them and meeting them where they're at in that original question that they have with us. And to Christine's point, we have people all the time saying, okay, I know, you're the climb, but I've heard about Rocksteady. And I say, go and observe and see what both are about. Because I said, I'll say, everybody's different and everybody enjoys something different. I might go to the gym and I might do yoga, and you might go to the gym and you might enjoy weightlifting, right? And we all enjoy different things. So I say, go and find what fits you best, because that's what you're going to enjoy. And if you enjoy it, that's what you're going to continue doing. And I feel like that is the biggest piece, is people need to start this, and they need to continue on this journey so that they don't go into, Christine was talking about them going home and shutting the door and being isolated. And that's what we don't want. And when they found the program and they got involved, that's when things started to brighten, right? And we want to do that for people. We want to make sure that they are feel surrounded and embraced, and we want to empower them to live their best lives with Parkinson's.
Excellent. Well, Jesse, I'm going to bring to you as well on the same topic. So, somebody is new to Parkinson's, or maybe they've been dealing with it for a while, and all of a sudden now, with memory compass, what's the experience going to be like when they come to you? Why do they come to you? How do they find out? Maybe they weren't thinking of what you do for that. So kind of fill in what that would be.
Yeah. So a majority of my patients from the start have said, why did my neurologist not refer me to you from the beginning? And just kind of building off of what everybody else is saying, it's like, you truly have to be your own advocate. And I I hope that changes one day. A lot of neurologists, they know for a speech language pathologist about the swallowing component, about the voice component, but they don't always think about that cognitive communication breakdown component. So they don't think to refer someone to a speech language pathologist for that. And that's crazy because we're in the healthcare profession too, right? So I think there's a lot of education that needs to be had, that I continue to try to have with neurologists in the area and geriatricians in the area, regarding how a speech language pathologist can also help with that cognitive communication breakdown in the home. So what happens is, Indiana, we're a direct access state. So you actually can request therapy. Like, somebody can contact me directly for therapy. But I prefer to have an order because your physician will sign off on your therapy plan of care. And I would like to have that communication between the physician and myself. So I'll give like family a little script of what to say when they notify their physician, maybe if they're contacting me directly and the physician's not referring. But what I do is I go into the home and I'm looking at not only the cognitive communication part of what's going on, like the breakdown, but I'm also just looking at the home environment. I'm looking at, should it maybe be set up a little bit in a different way to enhance memory function, to decrease frustration. We come up with different, visual aids. I have a gentleman with Parkinson's who I helped with, he has Lewy body and Parkinson's. He wanted to continue to use his computer, but the desktop was so overwhelming to him. So how can we modify some of the things so that he can still be able to do that? And how can we come up with sort of a script of how can he still access the computer independently and not feel like he's constantly having to ask his wife what to do? Therapy is so individualized. It's just like Julia, every patient is completely, totally different. So when I go into the home, sometimes it is just, I'm figuring out where they are cognitively. I'm doing an assessment. And then from there, coming up with appropriate approaches that families should use when communicating with their loved one to decrease that social isolation, to decrease that frustration, to help with word finding, to help put different tools and strategies and systems in place. So therapy is very much for not only the individual, but also for the care partner. And I do that, like I said, in the home or also through telehealth.
Excellent. Well,
Can
we had a
I
question.
add to that just a second?
Yes, please, go ahead.
Okay, so you're talking a little bit about getting that referral to speech therapy, but I also want to address when the neurologist refers a patient and they say to me, I don't need this yet, or I speak just fine. And it's just my husband's problem. He can't understand me because he can't hear very well anymore. I hear that all the time. And that may be part of the problem, because husbands don't always listen so great. But and they can have hearing loss. But there is a really interesting phenomenon about the person with Parkinson's perception of how they talk. And it's quite common that they don't realize how much their speech has changed with the progression of the disease. And it's something that we as speech therapists work on from a variety of perspectives to help them recognize that, whether it's audio recording of them talking to us and where they can hear that difference between the volume or the precision of the speech production. And so that's something that where, again, education is so important, just to help them recognize that there is change happening, that we can, why not address it now? Let's just, really keep your communication skills as top notch as we can. But there's also the research that has looked at the effects of speech therapy with Parkinson's and the voice changes, is that, and with the cognitive aspect that can change over time, that if you do therapy earlier on in the progression of the disease, you're going to get more gains out of it up front. You're also going to have better long-term carryover of that. And so I guess I just want to throw out there that don't think you can't benefit from this, even if you're not noticing just really big changes in your speech yet. Early intervention is always better.
Yeah, I want to add on that, Julia. So I I will hear from some families either two things: we're not there yet, so I don't need you yet. We're not there yet. Or I think my loved one is too far progressed that I don't need you. But as a therapist, it's like we are here to work with someone and help support them, whether it's in the beginning or as a disease progresses. We have
through all phases of life.
Yes, throughout everything. And so it pains me when I hear we're not there yet, because I want to help where you are now, because I want to help with everyone's quality of life involved. You as the care partner and the individual with the diagnosis. And then, not there yet, or too far progressed. That's really when a lot of the swallowing comes in, as the disease progresses, therapy for that. The communication might be different. We're looking at things sometimes like body language and, training families on what to look for there as well. So there's no not there yet, and there's not too far. We're there for everything.
Right. Well said.
I will tell you what, on your speech, I have two speech pathologists here, but I remember when, in fact, I think Jesse's the first one that explained to me how this works, because I was dumbfounded. My uncle had a thyroid issue that was causing him to not be able to swallow. So he was having to have everything pureed, and then they were talking about doing a feeding tube and all these different kinds of things. And they prescribed a speech pathologist. I'm going, that makes no sense, but they taught him how to chew differently, whatever they did. And it's all normal. He has absolutely no, no, he can eat whatever he wants to eat, what have you. I was dumbfounded. I had no idea that you guys basically anything from here up is your world, so, but I think most people don't know these things. I know I didn't, so.
Most people just think we work on helping kids say S's and R's.
Exactly.
And I don't do that ever.
Well, we had someone ask a question, and Julia, you answered it really well, but I think maybe it could benefit other people to hear the question, is what is the difference between essential tremor and Parkinson's? So you already answered it once. I'll let you start, and if anybody else wants to add on, go ahead.
I gave a pretty general answer that, there are two different neurological diseases that respond differently, but need to be treated differently. And I said that just specific to voice, what I do, essential tremor is a harder thing to manage. It's a harder thing to see changes through therapy than voice with Parkinson's disease. And please, anybody else that wants to add on about essential tremor, go for it.
We do get quite a few inquiries at Rock Steady Boxing from people who have essential tremor wanting to join the program. And we have a medical advisory committee, and one of the professors, Dr. Connie Feames, she's on our board of directors, and she has essential tremor. So she understands the difference, and she's able to come up with a position statement. The exercise prescription for essential tremor versus Parkinson's is very different. So intense exercise is proven to be good for Parkinson's, but not necessarily essential tremor. And this is where we get into understanding our scope. We don't take people with essential tremor into the program. We don't take people with MS into the program. We know that we could cause harm because we know, basically, we need to know what we don't know.
Very good. Anybody else? I think Kim, you look like you're ready, or no? Okay.
No, I was just gonna say that, you know, exactly what Christine said. It's one of those where, you know, people will say, well, I have MS and I have balance issues, and can I do this? And we have to say, this program was developed for Parkinson's. We know Parkinson's, right? And this is a different type of neurological disease. So, you know, again, you know, just being very careful and letting people know that it's not that we're shutting the door to them. We're just making them understand that, hey, this is our scope. This is what we do, right? But, you know, those things that are outside of our scope, we have to be very careful with.
You guys have mentioned climb 2 or 3 different times, but I don't know if we've really defined what it is. So, you know, I think we kind of have an idea what boxing is, but what's climb?
Absolutely. So the climb exercise program, like I said, is geared towards all the different deficits of Parkinson's, and we work with quite a bit of stretching to reduce the rigidity, because we want people to be able to move the best way they can when they're in class. We want them to be able to make, you know, large exaggerated movements and to be able to move their body the best they can, so that they can take what they've gotten out of class and move better when they get home. So after the stretching, you know, we work on things that are going to help with posture. So helping them to stand up straight, use their core to have a really good upright posture, which again is going to help them with their balance, which is going to help them with reducing their fall risks. We want to help them with large movements, and a lot of times they're very exaggerated movements, like large stepping and large arm movements and things like that. And people might think, oh, this looks funny, or why am I doing, you know, and it just helps them move better when they get home. So a really big, you know, exaggerated movement in class is just going to help them move better throughout the rest of the day. We work on muscular re-education. So getting those muscles that aren't firing up that should be, getting them to work like they should be, and then getting those other muscles that are overcompensating and doing what they shouldn't be doing to let go. And this again creates this muscular balance that again helps them to move better with more confidence and better balance. And then we also have them exercise their voices, you know, doing things like, you know, voice exercises when we're doing hand flicks or things like that, making them say, ah, 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 or counting, or just simple facial expressions to help move their face and make sure it doesn't become rigid, because then that affects the way they speak, you know. Having them work out in front of a mirror and having them, you know, make sure they can see how they're moving, helps them to move better. So again, we work on a lot of different areas, and you know, of course, strength and coordination are all worked in there. But, you know, again, just addressing all of the different symptoms that Parkinson's has, and helping them to take what they do in the gym and take it home, so that they can continue to be independent and achieve those activities of daily living. And that achievement again feeds that positivity, which is again our end goal, you know, keep them empowered and positive throughout this journey.
Well, like Christine, you made a comment earlier, which obviously drew you into this world, was your husband, you know, early onset, 36 years old, you know, and so you found through the boxing and through the different things has been able to completely change his life. Well, how do we, and also earlier on, the different ones have talked about how difficult it is to get diagnosis sometimes, because there's not the blood test, there's not an easy scanning device to do that. How do we get information out to the folks that are listening now and in the future on this video, if they have themselves or a family member that is starting to show some signs. Can you kind of give us some indications of, you said everybody's different, what kind of signs to look for, what kind of process to go through to go out and search things? You know, we for 4 years kept asking, isn't there something else we can do here? What's going on here? And kept getting blown off. How do we navigate that? How do we give people a map to start looking through? And I don't care who starts with this. You guys can take off on this and add on to it. So,
You know, Jim, the initial onset of Parkinson's, typical Parkinson's, is pretty sneaky. And I think it was Julia that mentioned that it's easily dismissed as the aging process. Oh, I've always had bad posture. My handwriting has always been really bad. I've never had a strong voice. I've, you know, always choked on my food. But collectively, those symptoms, if you look at them on a list, and that was the aha moment for us, it all made sense that it's Parkinson's once you see those all together. So it goes back to education. But here's the fine line. If you start having these symptoms and you jump on the internet, you could get really, really scared. And we thought we had ALS before we were diagnosed with Parkinson's. So the Parkinson's was actually a relief for a minute. But I think neurologists are better at diagnosing Parkinson's. Young onset folks really seem to have a really difficult time getting diagnosed. And then there's the whole issue of minorities, and minorities are not being served. There's a huge population out there that is not being served that has Parkinson's. So the more that we can educate people about recognizing those initial symptoms, finding a trusted resource, and actually the Neuroscience Center here in Indianapolis has recently been designated a center of excellence from the Parkinson's Foundation. Woohoo! I get so excited about that because there were only 46 centers of excellence in the world, and we have one right here in Indianapolis. So that's a great go-to.
Well, Parkinson's disease is a movement disorder. So there are changes in movement. And when we talk about speech and voice changes, we talk about being hypokinetic, so smaller movements. And so there's just a lot of things that you can look for. Again, it's not always, you can have the similar symptoms that can fall under other categories, but movement is a real giveaway. Changes in posture and the length of your gait and balance, and help me out, ladies, what am I forgetting? Movement of the arms. I know neurologists will a lot of times have you walk down the hall and look at how your body moves while you're walking. Yeah. So
I want to add that, so a majority of my patients are Parkinson's with Lewy body dementia. And they were young, in their 60s. I feel like that's young. But anyway.
Younger every single day, I will tell you that. So, yeah.
So for my patients, they had about, like you said, Christine, like the 4 years or so. But it wasn't just all of the Parkinson's components of the voice and the swallow and the movement. They were also, one of the first symptoms was, I am not able to work like I was before in terms of like sequencing through my day-to-day. Like they were noticing either difficulty with, one of them had difficulty with spreadsheets, like keeping up their banking the same with spreadsheets, and another, it was difficulty staying on task at work, and they ended up getting laid off. So you really need to take a look at not just those more like the movement symptoms, but are there other things on the side, like sequencing and attention, that you aren't really taking into consideration to go on the other side of the list, you know, with the swallow and the voice and the movement. Because again, that can be, people think that that's just normal aging, and the majority of my Lewy body dementia patients were actually not diagnosed with the Parkinson's first or Lewy body. They were diagnosed with depression, and that was not something that, you know, the depression medications were actually detrimental to their system. That was not good for them. But it's needing to just make sure you weigh in both sides, and the things that you might not think of, like sequencing and staying on task, to be something to also look at, and make sure you're telling your neurologist, your doctor.
There was another symptom that I just thought of. We see a movement disorder specialist, and changes in sleep, acting out your dreams. And this isn't true for everyone, but a lot of folks with Parkinson's, many years before the motor symptoms show up, they're having, like you said, changes in, constipation, issues with sleep, not getting into the deep sleep that most people do, acting out your dreams. Those are some signs that neurologists are starting to say, hey, there might be something going on.
Acting out your dreams. Explain that one to me.
So most of us go into a paralysis when we sleep. We go into the deep sleep. Folks with Parkinson's have REM sleep disorder. Many people have to see a sleep specialist because for whatever reason, that mechanism is not working correctly. And a big percentage of folks with Parkinson's have had sleep issues for many years, hallucinations, acting out vivid dreams. So that's another area that, recruiting a specialist early on, because a good night's sleep makes the difference between functioning the next day and not being able to function. And folks are suffering unnecessarily with some of these symptoms when these specialists can be assisting you and having a better quality of life. So if I can speak to the people with Parkinson's that are listening, don't be afraid to reach out, and don't suffer unnecessarily with some of these symptoms. They can be managed, and people need to know that these symptoms can be managed with a proper, a trusted resource.
You brought
And
up,
I would say there's a lot that, people have to think about when they're, dealing with Parkinson's, the person with the disease and the care partner. And I encourage everybody that we talk to, I encourage everybody to keep a journal, because I'm like, you forget what you want to talk to your doctor about, right? And if you don't see your doctor but every 6 months, it's really important to take note of, I'm noticing that I'm not sleeping well, or if I am feeling like I sleep well, it means that I'm, having horrific dreams, and they're really vivid and scary. Or maybe, like a lady that we spoke with at one of our educational events, she had no idea that her hallucinations were tied with her Parkinson's, right? And it wasn't until it was brought up at an educational event that she tied the two together. So I encourage everybody, take the time to journal, so that when you go to your doctor, you don't just dress up real nice, and when they say, how you doing, you just go, I'm fine. I'm like, have those notes so you know what you want to talk to them about.
Twice you guys have brought up the hallucinations. I've seen commercials on TV talking about Parkinson's and hallucinations. You want to expand on that a little bit? Because I think we see these little 30-second commercials and trying to figure out what in the world they're trying to sell us. But what is the connection there?
Can I toss this back to Jesse and Julia while we have these amazing people here?
Yes, please.
That commercial caused such a reaction in our members. They were all talking about how horrible it was and how scary it was. And there's so much fear around dementia, and Lewy body dementia, to be specific, but also there's also just the slowing of the thought process, which is not necessarily dementia. And there's a lot of fear around that. And I think that commercial brought that to light for a lot of folks. Can you talk about the difference between bradyphrenia and dementia?
That's yours, Jesse. That is yours.
I actually have not. I keep hearing about this commercial, and I have never seen it because we do not have regular TV anymore. So I don't know what this commercial is all about. But yeah, so I mean, you with Parkinson's, you can have the hallucinations, and that does not mean that you're going to have Lewy body dementia. Lewy body dementia. So there is the slowing of thought process. There's slowing of there's slowing of attention to task. There's slowing of your thought processing. Maybe you need just one direction at a time versus multiple directions at a time. That's not Lewy body dementia, and that's not dementia. But it is as Parkinson's progresses, you can have those symptoms. Lewy body dementia, there's a lot more that goes on with that. It is, looking at for example, I have patients that they'll look at their faucet and they don't know what to do with it anymore. They know that they need to turn it on. They know that water comes out, but they do not know what to do. And that could happen at one time and it never happens again. They can go into their shower and it's the same thing. It's like, I know I need to get in the shower, but I don't know what I'm supposed to do. Like, not knowing what you're supposed to do with something that you do every day is completely different from just having, needing extra time to process something. So Lewy body dementia is more, there's a lot more hallucinations that happen with, getting up in the middle of the night and thinking that there is, I have a patient, they think that there's somebody laying on their floor. There's like 20 people laying on the floor. And so they don't get out of bed and they have to go to the bathroom, but they don't go because they think that there's somebody there. It's not scary for them, but which you think it would be. Or they're driving and, their brain's not processing that, they see multiple cars going by. So to them, it looks a lot different than it does to you or I. Because their brain's trying to catch up with what's going on. They become kind of fixated on certain things. So they could become fixated on, a lot of times it can be like their finances, maybe no longer being the one that's in control of the finances anymore. So that's definitely totally different than just, aging and Parkinson's together.
I am so glad I asked that question because, if it's, you guys are hearing this commercial story, so obviously it's scaring people. A lot of times sales are made by scaring people, unfortunately. I did a panel a few weeks back and I had a fire chief, a police chief, and I had somebody from the Attorney General's office, talking about scams and things to protect the people. And one of the things I asked the Attorney General was, and he had not heard about it when we did an initial conversation, but he had prepared for it by the time we did our thing. And it was one that was running, I haven't seen it for a while, but it was running all the time about people are stealing your house by stealing your title. Okay, I don't know if you've seen that commercial or not. And I come from a real estate background going, how in the world is that possible? And I go, we have not run into that at all. We do 3,000 transactions a year out of our office. How am I not running into this, And it turns out that it was pretty much a scam, but it was being run in a high profile commercial in the main things. I'm glad that we got a chance to have you guys talk about more, so maybe people aren't quite as afraid,
I feel like I could have talked about that for another 3 hours, but that was just the.
Yeah, I get it. Well, thank you so much, guys. It's, I cannot believe it. It's getting to be that time again. So I hate that. Does anybody have something you've got a forum and something you've always wanted to tell people? I'll go for it. Whoever, I'll let you, if you have something to say. Because I like, you just want to yell from a rooftop.
I would just start with saying if you even have considered the thought that this might be what you're dealing with, talk to someone right away and make sure that you're, starting to ask these questions so that you can make these connections early on, because I feel like, with most things, the earlier on, don't wait for the crisis. A lot of times Parkinson's is diagnosed after a really stressful situation like a death or maybe a divorce or even a surgery or traumatic event. But if you do feel like that you're dealing with Parkinson's or your loved one is, start asking questions and reach out to any one of us. The Indiana Parkinson Foundation is here to get you in contact with the right people. But I know all of the people on this call are doing the same thing. So get in contact with one of us.
Well, let me ask you a question. If you're suspecting, you don't know what's going on, your doctor's blowing you off like what we had, so are you the first person we should talk to somebody at Parkinson Foundation that have you direct traffic, or just you said anybody, but how would I know that boxing has any benefit or speech pathology has any benefit at that point, because I don't know these things yet? So
I think at the day of diagnosis, I would hope that the neurologist would have those resources like, you know what, you're going right into physical therapy. You're going right to a speech therapist. I wish that were the way that it is, but a lot of people upon diagnosis are just kind of set in motion and left to fend for themselves. So if you're newly diagnosed and you go home and you don't feel you have adequate resources, you really do have to be your own advocate. No one is going to do this for you. You have to assemble your team. And once you have your tribe around you, then you have some control back and you don't have to feel like this is an inevitable decline. I get emotional because I've been there.
I get it.
Well, and let me just quickly say that for voice and speech anyway, I'll not touch on Jesse's stuff, but if you're concerned about your voice, your speech, your ability to communicate in those ways, there are a couple of websites I would suggest to find a speech therapist close to where you are that is skilled in what you need in the specialty areas that you need. Not all speech therapists look alike or function alike. Not all of us have had those same training experiences. So lsvt global.org is the website for Lee Silverman Voice Therapy, and parkinsonvoiceproject.org is the other website where the Speak Out and Loud Crowd program comes from. And the reason I'm telling you those websites is that you can go and find trained therapists in your area that have gone through this certification or training. So reach out. I frequently get people calling me, how do I get this therapy that I see you do? And then we go through the proper channels to get the neurology referral and all that. But look for who in your area does what you need.
Excellent. Well, thank you very much. I'm going to do a real quick screen share and show you upcoming events here real quick. So thank you, ladies. This was phenomenal today. And as like always, these could go 2 or 3 hours. I mean, there's so much information that needs to get out. What we'll probably have to do is bring you all back together again in a few months to do like an update again and some more information. Next one we have coming up on the 23rd is, doesn't sound like a fun thing, but it's going to be stuff that's needed to be done, is, pre-planning final expenses and plans. We've got, some people involved in that. Rebecca Geyer with the elder law attorney has been writing some great blogs for Life Co-Pilot recently on that topic. So I'm like, you need to be on this, getting all your ducks in a row. So we have, new and improved medical care options. We have everything you need to know about Medicare coming up. So those are all events that will soon be here. You can always find those on Life's Co-Pilot. So that's our quest, is we're trying to educate. We're trying to bring this information. This video has been running live on Facebook on Life's Co-Pilot right now. So hopefully we've had people watching it. Thank you for those who've been attending today on Zoom. And we will then make this into a YouTube video. Unfortunately, one of the reasons I kept bringing up all your company throughout the thing is, unfortunately, when I clicked on record earlier, I missed some of the beginning ones. It didn't click, so it's a little late. But we made sure everybody's knows who everybody is, and I will put all your contact, if it's all right, I'll put your contact information on the thing when we push it out on social media and all that kind of stuff, so people can find you. So anything else you guys got to say before we go away today?
Thank you.
Okay, well, thank you for being here. I love having this kind of opportunity to share with people. So thank you very much. You guys were awesome.
Thank you, everybody.
Thanks.
See ya.